Good evening, all. There are people from multiple countries. Good morning, good afternoon, and good evening. Give us some time. We are just entering all the people in Zoom as well as YouTube Live. Give us some time. We'll be starting the session immediately. Meanwhile, those who are ready to come in video, please do so that we can see some faces. Even the faculty will be happy to see some faces, to talk to some people live. So those who can come in video, please do so. No compulsion, only if your bandwidth allows that, please do that. It will be definitely a motivation for the speaker to see people in front of them rather than talking to their own computers. Zoom waiting area getting filled up. Let's enter one by one quickly, and we are going to start anytime from now. Those who can come in video, please do so. That will really motivate the speaker. Extremely happy to see so many people coming in for a topic which has been repeated so many times last 2 months. I can even see people attending for the second time. Thank you so much for the support shown to online dentistry and the programs by online dentistry. Please switch on your videos if you can, so that we can see some Dr. Munish Chandran. Thank you so much, sir. Very happy to see familiar faces coming in. Give us a couple of minutes more. We will be starting in 2 minutes time. Let's stabilize the Zoom waiting area as well as the YouTube live sessions. Give us 2 minutes time. Dr. Joe, are we stabilized in Zoom as well as YouTube? Can we start?
Yes, we are stable, sir. We can start.
Okay. Those who can come in video, please do so. As I told you, it will be a motivation for the speaker. Thank you so much for coming in big numbers once again. Welcome to online dentistry. Welcome to the free webinar by online dentistry. Now, for those people who are new to this platform, online dentistry started with a motto that is redefine dental education. And believe me, we redefined dental education. We changed the whole concept of dental education. We changed the way dentistry can be dealt with, can be seen altogether. We established this firm in 2008. We established this firm in 2008 with the name Online Dentistry. At that time, there was nothing called online. It was only offline courses. But the name of the firm from 2008 onwards is Online Dentistry. But last year, almost same time, March 21, couple of days before the original lockdown by the government of India, we started our online programs. Now it's over 1 year we are doing this online courses. Conducted more than 412 online courses, and we have around 15,500 plus people in the website registered at this point of time. Thank you so much for the support. Thank you so much for the referrals given to our programs. Myself, Dr. Binu Abraham, orthodontist practicing in Kochi. Myself and Dr. Joby together started this firm in 2008. Dr. Joby is my consultant pediatric dentist in my clinic. Every Fridays, morning 8 a.m. to almost 6 p.m. He's in my clinic as a consultant pediatric dentist. And after 6 p.m., we sit together and discuss because we both were passionate in teaching. And then we understood that there's a lot of scope in a lot of departments requires a lot of teaching. That is how we started this firm. 2008, we started. Dr. Joby, pediatric dentist, head of the department, Malabar Dental College, Kerala. He's the head of the academics of online dentistry at this point of time. And he's a speaker of tonight. I take this opportunity to even welcome the speaker and introduce the speaker tonight, Dr. Joby Peter, one of the finest pediatric dentists I've ever met. And with his skills, my clinic has been taken into a different level altogether for the last 12, 13 years. So, Dr. Joby Peter is the founder of online dentistry and the head of academics, speaker for tonight. I take this opportunity to even introduce the speaker. We online dentistry has almost 10 centers all around India at this point of time. We conducted classes, offline classes all around India in almost 10 centers last 12 odd years. But all the offline courses are suspended for the time being due to the pandemic. We wanted to restart it last month, but again, we heard about a peak coming up again, and it happened. Now it's peak in Kerala again with a positivity rate in Kerala more than 10%. So things are not showing good signs at this point of time. We have suspended all the offline programs. We are going to announce the commencement of our offline programs soon. Let's hope and pray that this pandemic gets over and let's come back to normalcy. Forget putting mask. It's okay. We'll put the mask, but let's travel. Let's have some classes. Let's learn. Let's enjoy. Hope it happens soon. Now, at this point of time, we have two types of webinars. Those are 1 hour free webinars. 1 hour free webinar is the one you're attending at this point of time. Today's program is a 1 hour free webinar. And we have 3 to 5 hour long Sunday paid webinars. There are two types of programs happening at this point of time. And the one you're attending tonight is a free webinar by Dr. Joby Peter. Guys, there are a lot of stuff coming up. The Caries Management free webinar, which you are attending tonight, there is a second part next Sunday. Next Sunday, same time, there's a second part to it. Do not miss it. Those who are attending tonight, please do not miss next Sundays. And the Sunday after that, we have a 1 full day paid webinar on Caries Management. That is an amazing program already conducted last month. Big hit. So big that in the history of an online paid class, we had more than 92 candidates attending it. So we decided to relaunch it, and it's being relaunched the week after that. All the dates will come in the WhatsApp group you are in. If you're not in one of our WhatsApp group, please make sure you are in one of our WhatsApp group. I will tell you the phone numbers to personally message. If anybody listening to me at this point of time is not in our WhatsApp group, please be in one of the group so that you get all the updates. And we are making the best effort not to spoil the WhatsApp group with unnecessary forwards and all that. Anybody putting happy Easter, happy this thing, we immediately personally contact and tell to please delete it. We don't need that. You have 100 other groups to know all that. This is a pure academic group of online dentistry. Sectional orthodontics, amazing program again. I mean, it's not nice to say that's an amazing program because I am the faculty, but pediatric cases being treated with brackets and wires, something that can replace the Z spring and the finger spring, guys, it has a lot of value. We conducted a program last month again, and that was a big hit again. We had to restrict it to 30 candidates. 48 hours after the announcement, 30 candidates got filled. We had to stop it right there. And for the remaining people, we are opening up one more batch. May 2nd, there's one more batch, exclusively dealing with what are brackets, where to fix it, how to fix it, which wire to put, how to move the teeth. Pure basics, but aimed at 4 teeth, no canine premolar, 80 and 9-year, 10-year, mixed dentition, simple cross bites, simple diastema closures, forget finger springs, Z springs. Let's do guaranteed results. Let's get guaranteed results with sectional orthodontics. So do not miss that also. Unconscious patient in a dental chair. All dental practitioners here, it's a request from my side. Do not miss this program by none other than Dr. George Paul, one of the finest oral and maxillofacial surgeon in India, one of the most famous oral and maxillofacial surgeon in the whole world, who has even a law degree and advocate himself, Dr. George Paul, Dr. George Paul, came into our platform almost exactly a year before during lockdown period. And that was the program. We got record registrations in Zoom. We had 4,000 registrations to listen to Dr. George Paul class. Sir is coming again. This time he's going to talk about unconscious patient in a dental chair. Guys, any practitioner listening to me, this can happen to anybody. It has happened to me multiple times in my last 25 years of practice. It can happen to anybody. Patient just unconscious. What do? How do you approach? What all are we supposed to do? What all are we supposed to not to do? Backups we require, medicines we require, emergency medicines we require. Please listen to Sir. That to being an advocate, you have to look at that legal part too. There is no other way other than listening to George Paul, sir, on this program. Please do not miss it. Now, another program, Panoramic Radiographs. Oh my God, I'm taking OPGs every day. What is there to talk about OPG? Guys, I'm going to post you an OPG pretty soon in all the groups. You will have to come to a diagnosis by looking at the OPG. We'll do that soon. Dr. Eldo Koshi is coming up with a program on exactly how to look at OPG, what all to look at an OPG. Do not miss it. It is such an important tool in private practice. Then comes CBCT. If somebody can explain CBCT so well, my God, it is so important. I wish somebody explained to me during my earlier times when I started CBCTs. I had to learn myself. Now classes are coming up. Classes are coming up. All about CBCTs coming up. Then orthodontic mini implants. That's again by myself. Orthodontic mini implants. Those are mini implants used by orthodontists, but those programs are aimed at general dentistry, where the mini implant can be used for multiple other purposes, not just orthodontic purposes. So prosthodontic purposes, pediatric dentistry purposes, all that will be explained in the orthodontic mini implant program coming up. Watch out, be in the group, be in the website, register the website. You get all the updates of the great programs coming up. Do not miss it. And as part of our 1 year anniversary into the lockdown, into the online courses that we started, as part of the anniversary, we are even planning to come out with our last year April May programs. Pulpotomy, pulpectomy, young permanent teeth, basic dental photography, all that coming up soon, which I'm sure many in this group have heard before, but please refer to your friends. Let the new generation dentists, let the new generation house surgeons, let everybody get benefited with it. Please refer to your friends. Guys, this is information, pure information, practical information being passed over to all the dental fraternity. Do not miss any of this. And the most important thing that happened in the last 1 year is our association with Lincoln University, Faculty of Dentistry, Lincoln University, Malaysia. So the many of the programs coming up by online dentistry will be affiliated to Lincoln University. So all those who are attending will be eligible for a certificate from Faculty of Dentistry, Lincoln University, Malaysia. Do not miss those programs also. And as I told you earlier, those who are still not in our WhatsApp groups, please contact these numbers. This is myself, 98470 or Dr. Jobby is 94463 Please put a personal WhatsApp into these numbers. We'll add you to the groups. Be there, be silent, no issue. But you can get all the updates of the programs coming up. That's it. I don't want to waste any more time. Over to Dr. Jobby for that great session, which has been repeated multiple times. But I'm sure when Dr. Jobby repeats a topic, he makes it a point that he has something new every time. That's why we have so many regular, repeated. Dr. Lakshmi Shekhar is also there, ma'am. Thank you so much, ma'am, for coming in here. So we have people who have already attended this program. Dr. Nayan Sri, thank you so much for coming in. Over to you, Dr. Jobby.
Yes, Bina. Can you hear me, Bina?
Yes, perfect, perfect.
Yeah, perfect. Thank you so much. Thank you so much. Can you stop the share, please? Can I have a help? Is it my slides are visible? My sounds and my slides are visible?
Yes, Jobby, slide is visible and audio is perfect. Go ahead, you can start.
Yeah, thank you. Thank you so much, Dr. Binu. Thank you all for coming back again for a multiple time repeated webinar. Last week, I did this webinar for South African Society of Dental Association, SADA, for a 1 hour lecture. There are around 400 to 500 participants from South Africa. And that was a great response regarding this program. then we repeated this program many times, but still we are getting lots and lots of inquiries and requests of this webinar. And you know, this webinar is available for free for 2-hour webinar, and around 2000 plus views are already there in YouTube also. But you know, my webinars, each webinar I change, I put new studies, and that's how we have to learn, because I'm an academician and to learn, but all are clinically oriented. I will never talk something boring to you and something where you go to sleep. Don't worry, it's all going to be all clinically oriented topic. And that's why the trust that you have shown for such a webinar, which has been repeated for many times, still people in YouTube and in Zoom are be with me. Really, it's going to help you a lot, because I'm going to discuss something new that has come, and you will be benefited from that also. So this is a series of webinar. Now that comes the difficult part. Let me tell you, before start of this webinar itself, if you attend this part, you might be feel little itchy, saying that, oh my God, Dr. Joby should have covered that part also. Dr. Joby, why don't you cover that also? Your many of the questions is going to come up and pop up like that. Dr. Joby, what about that? How will you do that? Wait for one more week. Read for one more week and come back on next Sunday exactly at the same time. Don't miss it. I will never disappoint you. You will get new points, because it's a series of webinar series. Part 1 is going to be today. Today I'm going to cover some aspect of it, and rest of the aspect which we have told as a key discussion will be covered on next Sunday exactly same time 8 p.m. IST. So do not miss that also. So I know everybody settled down. I hope everybody had dinner. And you know, the males, especially the males, when you have a dinner, after a dinner or after a heavy meal, if it's a lunch or if it's a breakfast or if it's a dinner, they like to smoke. Okay. I had a very heavy dinner now. So I would like to smoke now. One cigar, one smoke. I hope you don't mind that. I want to take one puff and then start to get that feeling of every person who feel to get a puff after having a heavy lunch or a dinner. That's natural. That's very natural. I know many people are smiling because it's they have met their friends. You know, they after a lunch or thing they go to one corner and they take a puff. Do you know? Let me ask you very vigilantly. Do you know the number of untreated caries, number of caries prevalence in India is 3 times more than the total number of people who are using tobacco altogether. Tobacco has got cigarettes, gutka, so many other methods are there. I've thrown my cigarettes. I'm not smoking. I'm not a smoker. In fact, I'm against that. I did a world or all India campaign against anti-tobacco. That's why authoritatively, let me tell you, the number of untreated caries in India is 3 times more than total number of people who smoke or use tobacco. We have around 78% of untreated dental caries in Indian population among 34 to 44 years of age group. I'm talking about middle age group. And tobacco use is 28, but that I'm not promoting that. Why I want to tell you is there was a huge campaign all over India, and I was a part of that campaign called Tobacco Free India campaign. We visited 13 states, 28 days promoting, telling them do not use this with promotional videos. We did that. And As a result of that, there is a drastic reduction in the tobacco use. 72% of people of India are non-smokers. They don't touch tobacco. But only 22% of people in India are totally caries free. That's so, but we have maximum number of dental colleges. We have maximum number of groups, IDA, whatever. They did everything. I was a part of that IDA, which tried to uplift that. The difference is we have not reached the mass till now. Now, Dr. Joby, you are talking about India. What about the world? So please let me tell you one thing, that I'm not promoting something there. Tobacco is bad. People have understood the bad or adverse effect of tobacco. It can cause cancer. It is dangerous. It is that, blah, blah, blah. They know. How did they know about it? There was a huge workforce behind that, which promoted it. I was a part about that. But when it comes to dental caries, it's a tooth. No, why can't you pull out that teeth? You just pull out that matter over. That is the concept till now. Many parts till now, that is the concept. The awareness, the value of a tooth, or the belief that if you remove that particular tooth, which is caries, I pluck it and remove it, that means the entire caries is over for that person. That is the belief the general population have. And that is the belief even dentists still hang on their neck, saying that I'm a dentist, I'm an MDS. That is the difference between two studies which I've told you. All over the world, it is the same. Believe me, it is not in India. All over the world, whichever continent you are, be it in US, be it in South America, be it in Africa, wherever you are, the scenario is the same, because the burden of dental caries all over the globe is 2.4 billion untreated cavities. In India, we say crores, so 240 crores of untreated caries all over the world is there. And this is adult one. Okay, so Dr. Joby, what about this is permanent dentition. So what about the primary dentition? It's also not worse than that. So this is a disease which starts in the primary dentition, and we say, still dentists say that it's a milk teeth, it's going to shed off. Do not worry, don't get treated, nothing's going to happen. Permanent, it will be safe. Look at the effect there. This is the latest study of burden. You can search burden of global dental caries. It's there. So primary dentition, it is only 62 crore. Permanent dentition, 240 crore. It's not the difference between that number of it is that it transfers there. We have ignored it. The dentist themselves ourselves says that parents and confirms that it's a milk teeth, it's going to shut off. It's not about it, not bother about it. But now in a study in India showed every 100% of the population whom they surveyed had one or the other effect of dental caries. 100% had one or the other effect of dental caries. Either it is completely filled and is fine, or it is initial state, or in a different stage. 12 is the DMFT. 12. DMFT score is 12. So tomorrow in our clinic, if a case comes, which patient says, this is a case came to me. Patient says, sir, I have a food lodgement in one this one, I just want to fill that. So I asked him when it happened. Sir, it was there for 2 to 3 months. I was very busy. A lot of business activity and works were there. So I thought now, and that day he came. That was an election day. This is a real lifetime story that has happened to me. He came on the election day. So because election day nobody will come, so his business is closed. So he said, I will come on that day. So he walked in. Said, I said, I cannot fill you on this day. I'm sorry, I cannot fill you on. If you want me to be filled on this, you come at what particular time, because I can see there is another caries which is already restored on him. And when I started taking the history, he said, doctor, around 3 months back, this was filled by somebody. I said, cool. One dentist nearby only filled. I didn't go into the history of that. He filled it, but when I chewed it, it broke. Oh, that means he had already gone to a dentist. He has filled it and it's not staying now. For 2 to 3 weeks, it was having no nothing. Now one is convenient date to fill. For him, what it is that just fill it, what the dentist job it is. He just fill it, that's it. That's why he came to me. He said, no, I cannot fill it. So generally what is happening is whenever this kind of case comes, many clinics, I know what happens. Some immediately nice filling is done, composite person. I said I have a composite. No, nowadays whenever they ask you, you do amalgam. Oh, it is silver amalgam poisonous. So nowadays it is not recommended. So we have ceramic and filling, zirconia filling in that. You have indirect and direct inlay, onlay, all those things which are made of a finest material, which has good strength. I will do that. We talked lots and lots and convinced the patient they are ready to do it. And you have done a good filling there also. That's your agility or your capability to do a good filling. You are good in composites or whatever it is. You have done that. But the problem comes, when the same patient comes back, oh, doctor, no, last 2 to 3 months back, you feel no that fracture. It came out, doctor. Oh, okay, fine. Let me see. You see that? You will say after seeing it, you will say, oh, the tooth is also fractured. Earlier it was very small. Now it has become the tooth is also fractured. So you might ask some questions like, did you have a lot of sweets and all? Oh, doctor, there was a marriage. 2 3 cousins' marriage was there in my that. So I was having lots of sweets. That is the reason you eat a lot of sweets. You should not touch sweets. You should not eat sweets. One alibi for us is that. Then we ask him, did you chew in that side? Yeah, last week I had a cashew nut, I had a badam, hard food. Oh, you didn't chew that side? No, 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 you are not supposed to chew it. That's because a huge cavity, it's inside side of the tooth. So there is no support. So it might fracture. So you should always chew on this side and the soft food. No, we ourselves are telling the patient that don't use that side. Use this side for hard food. Soft food, you use that side. There are so many alibis we used to tell. Finally, we put the blame onto the patient. Luckily, the patients, true to our nature, they do not complain. But some patient ask, I have experience with that. So isn't it something that is permanent? You do it. I will pay you how much ever you want. I will pay you how much I want that filling to stay. You have something that is permanently stick on to that. Early times we had something called silver amalgam. Nowadays, that we don't use it. Plus everything is like you have to take care. This like that we say that. We just try to avoid. No guarantee we can give. It's true. We cannot guarantee a patient's bite. We cannot guarantee a filling that is going to be sustained in the mouth. Nobody in this world can guarantee it. It's true. But did we miss something in doing a simple filling, a class 2 filling in a premolar or a molar or MO or DO or MOD? Have we missed something? So guys, what we are going to discuss in this series of webinar today and tomorrow, I mean next Sunday, we are going to discuss caries as a disease, identifying caries as a disease, understanding caries in a more appropriate way. Am I doing surgical model or am I doing medical model? What is a new paradigm shift in detection of caries? White spot lesion, one red light that should stuck your head before filling any class 1, class 2, any cavities according to GB Black. Any cavities according to GB Black, if you are going to fill in a patient, I will check first for something called white spot lesion. If it is present, I won't do filling for it. Informed decision making. Amazing part. This is my 34th, 39th slide. I have to discuss here lots and lots of practical application, which we never ever do that. You know, my first consultation appointment, I take 20 to 30 minutes, sometimes 45 to 1 hour I take, depending upon the this one. So that is one informed decision making. Here I make decision. Here I judge. I will do normal protocol. Whatever I do, I have to satisfy the patient. So here, there's no point in doing big things for this patient. Okay, this comes under this category. Let me do it. Let it get failed. I know I'm telling the patient that it is going to get failed. Let it be, because I've told them, I informed them. They will never complain. They will come back to you only. But other one, they follow perfect protocol and they say, oh doctor, that day, that time I spent with you was amazing. That changed our sons, daughters, or my attitude towards this. Informed decision making there. And newer methods of caries detection and ICDS classification is a must learn thing for general dentist. And interproximal caries and separators, what they can do, or the newer diagnostic tools that they could. And I'll be concluding in this session with that. So most probably by 10:10, 5 to 10:10 Indian Standard Time, I'll be done with my presentation. That's all. So first and the foremost is caries as a disease. How to manage that? James was running. He was having a morning walk. As he was having a morning walk, he felt some discomfort on his chest, tightness in his chest. He just sat down. Luckily, he had a friend, myself, Joby, was behind that. So when I saw what happened, James, he said, I'm having a discomfort. I stood with him. I said, what happened? I need to rush. So immediately he said some discomfort in the chest. We had to rush him to the hospital. Ambulance came. We rushed him to the hospital. They did ECG. The first protocol they do is an ECG. Then there's a variation. They said, well, let us go for an angiogram. They did an angiogram. And finally, they found out there's a block in his heart. And that is what is causing him that chest pain. My friend James has experienced that. He plays shuttle with me. He plays jogging with me. We used to do everything together. And he had this. So the option left in front of us is open heart surgery. So that was the only option. Multiple blocks, only option. So he had to undergo a surgical management of the condition what he's having there. So once everything is done, fine, he recovered, he's fine. Still now we jogging and we are doing it, he's fine. And he asked me, Dr. Joby, you're a doctor, I'm a layman, I don't know. What could be the reason for my condition? So we went to his entire results and we found out that he had high cholesterol, high thing, everything was there. So when I asked him his history, is that his lifestyle is he's tensed, He's a businessman. He party with his friends, lifestyle, no sleep, anytime. Everything is not normal. All are like managed, managed, managed. And now he is 46, along with my age group. So there was a thing that is happening which caused him into a tabular column which says that he's at high risk. So now what has happened is after the surgery is done, everything is done, he's discharged from the hospital. But one thing the doctor told to him is, you don't have another heart. You have only one heart. You can't have another heart there. So if you want to live more, you have to follow some protocols. You have to understand why you had that problem. There is no looking back if you want to survive. So you have to modify your diet. You have to control your eating habit, your drinking habit, your smoking habit. A lot of things you have to be controlled. Lifestyle modifications required. There are some drugs it's inevitable now unless you modify them. You need some drugs. And mandatorily, I'm a cardiologist. You have to come and meet me at this particular period of time. It's like a list given to him. He has to do now. So guys, James is saved, but it's a surgical management of disease that is being done. There was a surgery performed, split open his chest, and the block and the bypass is done. He's surviving with only one heart available for him. He's surviving, and he need to modify this to make that bypassed one doesn't get another block there. So this was surgical management of the disease. Yusuf once came to me with severe pain. Sir, severe pain. I had 6 to 7 patients waiting, but it's an emergency. He came to me saying that, sir, please do see me. So assistant came, sir, severe pain. He's crying, he's yelling, he's turning. Can you see? So when I opened the mouth, I could say that this was a condition. Severe pain, unbearable pain, but touch the tooth, severe pain for you. So what could be the option for it? IOP, you can take it or not, but definitely you know that it's a pulpal involvement. Severe pulpitis is having it, and you need an emergency. Either you only open it up, or whatever procedure you need, you can give medication, whatever discuss. The option is again surgical management here. Surgical management is the only option. Either you surgically remove the tooth by extraction, or you surgically open it up to do root canal and give a crown. That's it. There's no other option in front of you. You can't reverse it back. So that's surgical management. Now, let us pause for a moment and think that James, if he would have gone and done a regular physician checkup with blood evaluation, if he would have done, and when the value he shoots up and he knows that, okay, fine, I had a party yesterday, I had a good food habit is not controlled, I did not, for the past 1 month, I did not do my regular exercises. If that is being educated to the patient, or patient is aware about it, he would have never ended up in that surgical table. He would have modified the diet, modified the lifestyle. Drugs not need to follow up to sustain for a longer period of time. Now, that is called the medical model of management of a disease. Now, here the question is, dear friends, the question is, you understood that a disease is there in him. You understood that the heart attack or the heart block or the chest pain he showed is not the disease. It's a sign and symptom. That's it. Very simple. You understood the sudden chest pain he felt and collapsed, sign and symptom. The heart block is a sign and symptom. The disease is cardiovascular, a cardiovascular disease, nothing related to the sign and symptom. So identification of sign and symptom is important, or identification of the disease which James is already having is important, is what is called medical model of management of caries. Look at this, a premolar, it's got a cavity. Now it has got a frank cavitation is there. If and if this patient would have come back or came to us, and when we saw those brownish deep fissures and all, we saw them, told them that it is risky. Some patient accepts, some doesn't, and you do a sealant application or whatever methodology, if you do, you would have prevented that cavitation that is happening. So either surgical management of caries is only option. Drill till you reach pulp. Once you reach pulp, do root canal or extract it, keep implant. Again, that is a surgical man. Implant is also surgical management. You are doing surgery, putting something inside. That is one option, or medical management, preventing it before it is happening. So the difference is you should be have a methodological, you should have an accurate methodological mode of understanding this disease first. And you should have a protocol to diagnose it, detect it, assess it, then start treatment. It's no more composite. You can buy Ivoclar, 3M, whichever company composites which are best they promote, you can buy and keep it. But you cannot apply for this for all patients. Why? We don't understand that it's going to be a big failure. So many times I bought the best 3M, but 3M is not good. It is not packable. It is sticky. So many questions. But let me tell you, one of the best company according to the manufacturer. But they never tell you that, oh, this should be applied for this condition, this disease. They say for this cavity, which this cavity, you fill it, it will be good. But is that cavity is ready to receive a filling? Is there is any other disease process is happening in the cavity? You have no idea. You have not diagnosed it. You see a pit, you fill it. You think that the material will take care of you. It's not going to be take care of you, because each material is technique sensitive. It is either tooth sensitive. Let me tell you, tooth sensitive because dentine is required, enamel is required, everything is required, even highly technique sensitive. Amalgam was not like that, technique sensitive. You make a hole, you put it, packed it inside, it will stay there. Amalgam was like that. But composite and GIC are not like that. It is very technique sensitive. So if you want to do the surgical management of the caries, let me tell you, you have to assess lots of other things. Otherwise, you can see your fissure sealants will be within a month or 3 months, 6 months, all will be coming out, and you can see a strip of sealant sitting there. You did a beautiful composite, but it gets fractured. It came out. It's not staying there, or patient says staying there. So this is the medical model of management, and here is the surgical model of management. Now you tell me which gives you maximum guarantee or which gives you less compliance. It's up to you to decide. Medical model will definitely will give you less compliance. Patients are happy. That feeling you did not, still remains now. But this surgical model has got its own limitation there. So now I'm coming to the theory of what dental caries you and me understood is not now. It is changed a lot. I'm sorry to say that you might curse me, Dr. Joby. This is not the time. These wee hours of 8:45 is not the time to listen to any definitions, what you say. But This is a definition that you should understand and learn, that it is an infectious and transmissible disease, because I consult my many of the pediatric cases. When I consult, many time mother says, doctor, you know, my husband family is full of caries. My husband's mother, everybody, brother, everybody has got caries. That is my reason my daughter is having caries. When it's a her husband is a, my wife's, no sir, my wife's family is full of caries. Her grandmother is full danger only, full teeth are removed. So the blame game is continuing. But let me tell you, we dentists should understand that it's an infectious and transmissible disease. And one important thing in this definition is it is not caused by any extra oral pathogen. That means your mouth, my mouth, Dr. Binu's mouth, our team mouths, your team mouths, if you evaluate, everybody has got the common cells. They are the normal common cells present. They should be present there. That means it's not like a COVID, or it's not like your other bacterial infection or other viral, like a leprosy or any other viral infection. No, it's not an extraoral pathogen that is suddenly coming and creating. No, it is the your own pathogen that is present in your mouth, my mouth, anybody's mouth. It is present. This guy is causing it. Then why Dr. Joby doesn't have caries and that person has got more caries? The same pathogen which is present in myself and that person is present in both of our mouth, but they are aggressive or more stronger. Their number is more stronger. That is why I don't have that much caries and other person who's sitting in front of you have more caries. It is not like his fault. There is more pathogen than that is there in your mouth. So that is what this definition says. It is not an extra or alien that has come suddenly and it started growing inside the mouth of the patient. No, your own pathogen present in you and me is there in every human being, and that pathogen is causing it. So they are normal commensals. They are not culprits there, but they become a culprit because of some reasons. So we have to understand this as a disease. Now I am coming to the point. Now I am coming to the point. Everybody eat chicken. Everybody eat non-veg and veg. But some people doesn't jog or do some activity. They have a sedentary life. And those people are the one who are more inflicted to become a cardiac disease. So there are multi-factors that causes that disease, and the signs and symptoms of the disease is chest pain or collapse. Exactly. I eat a lot of sweets. So many people eat a lot of sweets. They don't have caries. But once in a week, the patient eats sweets. He's got a lot of caries. So it is a disease. It's not a condition that you understand. So what is happening is a disease. Dental caries is a disease. It's a multifactorial thing. Not your sweets alone is the reason. Multifactorial disease that is happening here. So what is happening in this child mouth is a disease. And cavity discoloration, whatever you see, it's a sign and symptom. That is a sign and symptom. Disease is all together. There is some other reason for this sign and symptom to develop. For a cardiac patient, the sign and symptom develop either food habit or whatever. Something is there. Then only it develops that. So it can be hereditary or it can be a local factors. There is something else is happening for this patient to develop a disease called dental caries. So it's a multifactorial disease there. Look at this picture, A and B. If you see this picture, A and B, you can see the difference. You can see the morphology of the tooth itself is very risky. Look at the number of fissures and things are there compared to A and B. A is more prone because fissures are narrow, deep, multiple fissures are there. B is a well collapsed, widened fissures, safe, less chance of this. So this is one factor. Tooth itself is one factor. Mulberry-like molars. Syphilis, you can see mulberry molars. That doesn't mean you can have a mulberry, but this patient doesn't have syphilis also. But this is what I just want to put in your mind, that multiple tortuous fissures are present. They are highly susceptible for caries compared to this one. Definitely. In India, before breakfast or before food, there is sweets. After food, there is another type of sweets. And in between sweets, sweets is something like which we love. I know every part of the world, I don't think so. Any part of the world, they don't like sweets. The sugar, the arch criminal. So that's one part. I have not time to explain, but let me tell you, diet for substrate or the environment carbohydrate, the arch criminal is one thing that you need to take care. And the most important thing is the frequency of snacking. And then comes your hygiene. Hygiene. So many times we will be doing bridges, 6 to 6 bridges or whatever, but lower teeth has got this kind of calculus and we never get bothered about it. We never ask the patient about that. We do fillings, we do so many things in patients, but we doesn't see the host factors, the oral hygiene factors. We are too much into that filling. The patient says that the host factor, the hygiene factor, or the daily maintenance of the hygiene factors are there. And then comes the agent. As you all know, agent is another factor which has to be taken into consideration. And this is another case. This I just want to show you is an 8-year-old patient came with a filling for a primary molar, second molar. We did the filling and they sent them. And after, when the patient was 10 years of age, the same patient came back with a, luckily my filling in the E is staying, but I could see a same kind of filling or a cavitation that is happening in the first permanent molar. That's a 2-year gap. 2-year gap. So patient had some kind of discomfort in that, and I got the filling done. Patient's happy. But when the first permanent molar had some problem of food impaction, they're not bothered. When pain or some kind of discomfort came, they started coming back. So there's a 2-year gap. So time. It's not one day you have it, multiple time, many number of times. That's a problem there. So that's the normal. Any disease, they have now found out that you need a host, a substrate, and a flora to cause a disease. But for dental caries, they found out that that's called web of causation in epidemiology. Any 3 factors should be present. But recently, Dr. Newbern added time is also required. Sufficient amount of time should be present to do a caries. So then you will have a cavitation or you will have this thing. So this led into further research. Okay, that means if there is a time is present, then only a cavity that is formed. Then research started going on to that. Why don't we diagnose or why don't we detect it early before cavitation? Is the reason signs and symptoms are there? Why don't we identify those signs and symptoms which doesn't form a cavitation, and much before that we can prevent? That's the world now. That's the caries management now. That is why, let me tell you, a beautiful beach, and I love to make a home in this beach, but nobody will make a permanent home on the beach because the sands are not stable there. I cannot build a good stable home there. At any time it can be washed away, it can be sunk inside. For a marshy land, I will never buy a marshy land and try to build a home there. Exactly the same way, if you want to do a filling, you should make sure the tooth is strong, the enamel is strong, because you are using material which bonds to the enamel or dentine. So make sure the dentine is sound or enamel is sound. A tooth where the enamel and dentine is not sound, please, no filling, no Ivoclar 3M, best one is not going to stay there. It's going to be dislodged. or get fractured. It's not because of the manufacturer problem. It's because of your problem of not identifying the condition, the disease that is happening there. So you need a sound enamel, you need to do that. What about a place where dump yard is next to a, I will never go and build a house next to a dump yard where I will buy a cheaper land also. I will never go and mess there. Exactly the same thing. If the patient is not bothered in maintaining the oral hygiene, that mustard seed is being there in his mouth for ages, and when you open the mouth, you can get the putrefied smell of that. Into that patient, will you give a crown and tell them this is going to stay there? I don't think so. That kind of unhygienic oral mouth, you cannot do cavity filling there. Hygiene and awareness of the patient is important. Be it be permanent, be it be primary, let me tell you, in this kind of primary tooth, if you tell them I will undertake everything under general anesthesia or whatever, and I do every filling I will done, let me tell you, this patient will after 6 months will come back, that thing came off, a new caries came, that filling came off, that came off, I've experienced it. So first and the foremost thing is understand what is happening there. You can see potholes, so many potholes in India in summertime, sorry, in monsoon times, you can see a lot of potholes are there. And what you do in potholes, you repair the potholes, you fill the potholes and make it even so that potholes disappear. And what you need to do that, you need a tool to fill the pothole. You have to clean the pothole, and after cleaning and shaping the pothole, and then you fill with the cement and make it smooth. That's what we do with potholes. So the tool you have, or the person to fill the pothole, is a axe. Now, we dentists who are dealing with the dental caries to fill a cavity is having an exact same tool to clean the tooth, to make it wider. We are using the, right? So a pothole person is also using exact same axe. Only thing is it's mechanical. You have a you are automatic one. You are an automatic. You don't have to do anything. You just press it, it will rotate. So potholes are there in the mouth, and you look only filling. You are exactly what that pothole man is doing. Next monsoon came, it's going to be washed away. Next heavy bite comes, it's going to be fractured. And we dentists love to hear this sound daily in our clinic. Without this sound, we cannot find the day is fulfilled. That drill and fill sound. What are we doing here? We are cleaning the potholes, or we are removing the potholes, and then we are going to fill up with some material which expensive or other kind of materials we have bought, we are going to fill it up there. So the current concept is drill, fill, and build. You and me are doing exactly the same thing. Drill, clean it, then fill it with the cement and build the patient. This is what I used: composite, ceramic, the latest white color, matched. This is the build. We all are doing something called repairs. If you see a workshop fellow, a repair fellow, you take a bike, you take a car, now you can see this much armamentarium. We have this much armamentarium, either to pull out the teeth or to fill the teeth. So many types of burrs we have. We have round burrs, we have straight fissure burr, we have taper, different types of size and shape of burrs we have. We have different type of isolation materials, we have different types of cements. So all makes into one repair center. Yes, this is our workshop. Our clinic is like a workshop, like a repair center. You come, you have a cavity, I will drill and fill it. That's it. It's done. Now, the concept, the next generation concept is, how can I heal it? I can identify it. There's a definite healing center. I will drill it and fill it, whatever you have done. I will do that. But let me heal the process that is happening there. Let's not become a cavitation initially. Let's try to limit the number of cavitation that is inevitably going to happen in your clinic or in your mouth. Let me limit that. And whatever cavitation, I will fill it. Don't worry. But rest of the things, let me take care. Let me heal it so that they won't become a cavitation. So it's a healing center like conduct. You need a change in approach to do that. You need a change in approach to do that. Because all till now, what we are following is prevention or extension of decay. That means if decay is there, if a cavity is there, go and drill and make it bigger. So sound, dentine, and enamel has reached, and I will do a filling, and it will stay there. But the web of causation, which is being in epidemiology, is adopted to dental caries, where initially 3 reasons are there. So unless just fill it is not going to work out, you have to find out the 3 reasons and treat those 3 reasons in 1960. And then came sufficient component cost model of dental caries, where Newbrand's concept of time and other multifactorial components came. What is multifactorial? There are some factors which promote caries. There are some factors which decrease caries development. Identify those factors which promote caries, reduce them. Those factors which decrease caries, promote them. That is called sufficient component model of dental caries. And medical model of dental caries, like comparing dental caries with other medical diseases like a heart attack or a cardiovascular disease. It's a multifactorial thing. Identify them, then treat. And upon to that, ecological approaches came, where natural commensals are being promoted. Good, healthy bacteria are being promoted so that other bacteria doesn't get an upper hand. And the latest one is the Nexo model of caries management. So it's not a time to explain all those things, which will become in the next session. And that so things have changed in managing dental caries, and proven or scientific proven evidence are there with that. So understanding the caries as a disease is the first and the foremost thing in our practice there. Dentists should know the disease and its dynamic nature. It's not a single day process that is there. Then accordingly, you have to change the mode of the treatment. You need a sound enamel, sound dentine to put any cavity or a filling that you want. And patients should follow some of your protocols. Please don't say that every patient will follow your protocol. Some protocols which you say they should adhere into that. So now you have made the things understood the patient, then clinical diagnosis of the dental caries. How will you diagnose dental caries? What are the clinical diagnosis or change in the clinical diagnosis that is there? Now, those people who have not been into the literature, general practitioners are very rarely read literature. But let me tell you, 2005 to 2011 is a dramatic or a golden age where studies into dental caries have come. There they identified dental caries and dental decay differentiated them. The caries diagnosis and caries detection is different. Diagnosed as different. That's an amazing era that has happened, and that is why newer methodologies of caries things that has come. What you see here is not decay here. Here it is dental caries with decay. So a dentist should diagnose that the patient is having a dental caries, and he should detect and say that there is a decay is also present there. I hope you understood. Again, I will repeat, a dentist should diagnose in a patient that you have a dental caries, and he should detect accurately that you have dental decay. So dental decay can be cavitated and non-cavitated. So already only cavitation is not dental decay. With cavity, without cavity can be a dental decay. And all comes under the procedure called dental caries, a disease called dental caries. And you dentist has to diagnose it holistically. So if you take an example of any disease, for any disease, there should be signs and symptoms of a disease should be there. Once the patient says the signs is like a pain, like a food impaction, like a discoloration, patient says there's a signs and symptom. You have to verify the signs and symptoms. You have to detect or confirm the signs and symptoms of the patient. So you have to use some tools to detect or confirm the signs and symptoms. And then you have to only that particular, so patient might say discoloration one tooth, but as a dentist, you should see other tooth also. All the mouth you should see. And you say, okay, that particular tooth has got a cavity, fine. What patient says is good, but in that mouth, you have a problem, a disease. That patient is suffering from a huge disease called dental caries. So this could be one of the reasons the patient came. I saw the discoloration, doctor. Can you just check that? You checked it, you verified, yes, discoloration is there. So signs and symptoms you said, then detect, you see any catch or you see any cavitation is there, you see, yes, that is also there. You look other teeth also, which patient may not have seen it. Patient have not seen it. Initial white spot, nobody seen it. You look for that also. Multiple teeth have that also. So it is not that particular tooth that is having a problem. So you can use multiple methodology to identify the problem there. So you diagnose a disease is happening in that. And that disease is called dental caries. So this child or this patient is not having a dental decay. That is a signs and symptom. White spot lesion, that's a signs and symptom. Discoloration, that's a signs and symptom. But this child is having dental caries. And the signs and symptom of that is white spot lesion, cavitation, proximal caries, whatever it is. So it's not just filling those cavity is enough for this patient. You need more methods of caries management here. So comes into caries detection now. How to detect caries is the next part. So I will within 10 to 15 minutes, I will be finishing my, as I said, 1 hour, 10 minutes maximum. So another 10 minutes, I will be finishing this. So next important step is caries detection. As you all know, we do it with our probes. Probes are the one of the diagnostic tools that we use it to detect caries. Now, the question is, I'm not going into detail, is probe is the best diagnostic tool to detect dental caries? Is my next question. For that, let me not waste much of your time. Look at this patient, is a 13-year-old patient, came to me with discoloration. His problem is discoloration. So look at these cases, and what he said is, this is a discoloration, sir. I try to brush, I to rub it, but it is not going. This is my discoloration. So what is this discoloration? What you see in these areas, you might have seen some discoloration here, discoloration, brownish discoloration. This is all worrying him. So look at this closer for that. Now you can see that discoloration is not anything like, but it is called white spot lesion. Initial enamel decalcification, as if we have applied an HN, and when you apply an HN and dry the tooth, enamel appears whitish. Exactly that this whitish appearance is seen there. So that is what his worry. So what is that is happening in him is that whitish spot is the initial caries lesion called white spot lesion. What is this white spot lesion? This is something like subsurface demineralization. What is happening is the surface is very intact, but deeper and deeper, demineralization is predominantly happening. Demineralization is predominant. That means calcium and phosphate are out, and it is in the process of demineralization. So enamel, as you all know, enamel has a hydroxyapatite, which contain calcium and phosphate. They are the main supporting structure. This calcium and phosphate are being eliminated or removed. So what happens? The enamel apatite crumbles down. But they have not reached that state. What you see a cavitation is a crumble down enamel. But here it is an initial stage. It's not crumbled down. So that is called subsurface demineralization, where enamel is demineralized, but the surface layer is intact. Surface layer is intact because it is exposed to saliva, and the patient might take some fish, some can take some mouth rinses, take toothpaste. So each toothpaste and all contain fluoride. So this fluoride will go at initial surface, they will form a good layer, but deeper what is happening, it is undergoing demineralization. That is called surface demineralization. So what happens when you use a sharp explorer is that you are actually putting the sharp explorer and making them into a frank cavitation. So that is why you create a cavitation when you use a sharp explorer for initial caries detection. Whenever you see a white spot lesion, you should never use a sharp excavator. Second thing is you are inoculating the microorganism deeper inside because the microorganism, it is an intact surface. Now you made a frank cavitation and you used for another tooth. So the tip of the explorer might have some microorganism which is present on the another ecology. Now from that group, you are inoculating on into this and you're putting from the surface into deeper inside so that anaerobic microorganism can grow inside safely there. Export the microorganism on one side to other side. So according to the latest studies, what they say is tip of the explorer should be moved very gently across the surface. Should not be very like hard probing. You should never do that. Especially the non-cavitated area, you should never do that. So according to George Tukey, he's a very famous cardiologist in Michigan University, Indiana, and he says that use of a probe in the historical manner, like conventional way for a tactile examination of the tooth is contraindicated because you can injure white spot or make it a frank cavitation because they can be remineralized. So you should not be using a sharp explorer for that. So what he suggests is there's a new shift in the diagnostic tool is that step one is clean the tooth surface. So here, if you have a doubt or discoloration is there like this, you just clean with a toothbrush. You either ask the patient to bring the toothbrush or you give a toothbrush, just clean with the toothbrush and then evaluate it. Don't use a probe to evaluate that. If you have a rubber cup, your brush micromotor is there, micromotor, that's also sufficient enough to do that. And then see the discoloration or a cavitation that is present or not. If white spot is there, do not use a probe. Otherwise, you can use a probe, and that probe is used to see the tactile sensation of that. Second step is after drying it, after all the cleaning, you dry the tooth surface. So after all your cleaning, you dry the tooth surface with a 3-way syringe. Dry it and see the surface change. If there is a whitish discoloration is present, then it's called white spot lesion, which is the first sign of developing dental caries there. So if there is a white spot is there, do not use a probe. Okay, please, that is a confirmatory diagnosis saying that the initial white spot is present and caries is developing. That subsurface demineralization can be remineralized. I'll be talking in the next session about the remineralization technology. So white chalky enamel can be remineralized. Do not make it a frank cavitation there. It's possible in the primary and in the permanent dentition also. So what are advanced, if you want to read more about the advanced diagnostic tools, if you want, I have given the website where so many fluorescent induced diagnostic tools are available, like a spectra caries detection aid, Midwest kit. All this will give you the accurate measurement of initial caries demineralization and cavity formation. So if you want to read more, an article, Detection and Diagnosis of Early Caries Lesion by Gomez Sitar, which covers almost the latest diagnostic tools which are available currently. If you see the diagnose area, the fluorescent light microscopy, if the advantage is you just put this probe, just like a light pure, you put this probe, you can see areas where red lights will be there, which are initial white or initial demineralization state. Those areas do not probe there because there is a caries is developing there. So methodologies are there. Other methodologies, use of caries detecting dyes, you can use it. When you use this caries detecting dyes, these dyes will stain onto the infected dendine and leaving the affected dendine. So you can remove the infected dendine and leave the affected dendine because the affected dendine can remineralize so that you do not encroach onto the pulp. So you minimize the tooth removal with the help. So you open up the cavity and if you find doubt, apply this caries detecting dye so that you can see the infected dendine and remove the infected and leave the affected dendine there. So allow the soft affected dendine to remineralize themselves and reduce the risk of pulp exposure is there. Another important thing with this caries detecting is when the most important thing for any restoration, whether it be a class 1 or a class 2, is the orifices. The orifices or the side walls are very important. If there is any infected dendine that is present there, your bonding will fail. So you want to remove any infected dendine on the side walls or any caries remaining on the enamel and the caries dendine has to be removed. It has to go. Then only you can have a good composite filling or a GIC filling. So that is another important to remove all the infected dendine to get a good secured affected dendine which can be remineralized there. So the peripheral zone is very important for your bonding. Many times bonding failures or secondary caries happens because you left untreated or uninfected dendine inside the borders. And lately, you know that carisol or your brisk, you have a liquid solution, you apply onto the caries tooth and you wait for 2 to 3 minutes. They remove all infected dendine with the help of a spoon excavator. You can easily remove that, and you do not have to use a burr to move that also. So the informed decision making of caries management is very important. Now, with this all diagnostic tools, you have come to the diagnosis that patient is having a caries disease. Now, what you should do, guys, you should inform the patient that you have a disease called dental caries. Please tell them that not that tooth is important, other tooth are also affected. You have to understand dental decay or cavity is signs and symptoms. They are not disease. They are the signs and symptoms of the greater disease that you have identified there. White spot lesion is a disease. Is again signs and symptoms. So white spot, the cavity, all are signs and symptoms. So you get initial signs and symptoms as a white spot, then only the cavitation comes. And when you find these multiple white spot lesions and a decay, you need to understand that there is a greater problem that is happening in this patient. You need a risk assessment. Please, many people doesn't do, they ignore this thinking that, oh, this is something like big things. 2 to 3 minutes caries risk assessment we teach. This is just a simple form. 2 to 3 minutes, all that you need, telling the patient is in high risk or low risk. Just that's it. One form, 1 page form. That's it. It's a simple, less or more economical form we have. I'll show you that. So assessing the severity. With this, you will assess the severity. This lesion is severe or this lesion is in which stage of development is there. Then prophylactic and therapeutic. Many people do not follow the prophylactic and therapeutic care. We should discuss on the next class. We'll be discussing on that. And economical factor is very important. Sometimes patients' economical factor may not allow it, but there are cheaper ways to save a tooth rather than doing a big fillings or root canals and also those methods has to be followed in your practice there. So this is one simple 2 minutes to 3 minutes fillable form for a patient to judge whether he's high risk or low risk. So no time to explain, but we will be discussing in detail in the class. One thing that you should use is a plaque disclosing solution. Be it a one pediatric patient, adult patient, one motivation that can use is a plaque disclosing solution. Believe me, it costs you less than 12 rupees, Indian rupees per tablet. It's available in online. 12 to 15 rupees per patient tablets are available. Buy those tablets and use these tablets and show the patient that you have this kind of things because wherever plaque is high accumulated, there will be white spot lesion there. It's like a equal sign. High plaque underneath, white spot lesion will be there. So once you have this, what's next? Once you have this, what next is your question. Now comes the last part of my presentation. 5 more minutes. The last part of my presentation is you have to educate the patient now. You have done a beautiful job. Yes. Yes, doctor. My entire teeth is pinkish in color after using the disclosing solution. So what should I do? Is that make the patient happy or understand whole process called dental caries? No way. No way. Patient may say, okay, my hygiene is not good. I will do my hygiene. That's all. That's it. I will do my brushing better. That's not sufficient, guys. That's not sufficient. That's one tool which I told him to make him aware into a team. That's all. That is why I just want to take you into another thing called soft tissue lesions that is happening. Imagine a soft tissue lesion is happening in a patient. So initially there could be redness discoloration or multiple time ulcer that is forming. That ulcer that is formed, the initial tissue change that happens, and after that, the initial tissue change, when it happens for a long period of time, it goes benign stage, and then it goes to a malignant stage. So there is a soft tissue lesions which are malignant has got an initial stage which you can identify and detect and control it. Then only it become benign, and then only it become malignant stage. And in the malignant stage itself, there are stages are there. So that's how a soft tissue lesion goes. Then why can't the dental caries, which is a hard tissue lesion, can also have a initial stage, very minimal stage, little more bigger stage, little more bigger stage. When you tell the patient about this, see, madam, you have a cavity only there, no problem, it's fine. No, madam, you have a DO, madam, you have a MO, all four cluster involved. So they will understand the seriousness of each tooth they are going through. So that is called stepwise progress of the lesion has to be informed to the parents or the patients. They should understand that. So dental caries doesn't happen all of a sudden. It happens in a multiple stage. So each stage, you should tell them each tooth is in this stage, each surface of the tooth is in this stage. I can prevent that. I can help that. I can't help that. I can't help this. That is why treatment protocol, when you say you came for a filling, okay, for that tooth, the MO filling, I will do. This is in this stage, I will do the filling. But you know, DO, there is a caries that is developing. Or occlusal side, there is a caries that is developing. You know, the next premolar, there is a caries. You tell them, let them not take the treatment. They are worried about that filling. Let them do it and go. That is called informed caries management. You informed, right? You took it in the case sheet. You assess the caries assessment. You leave it. There's lots to learn about that protocol that can save you, and the future is that is going to come. So one system that is now widely followed is International Caries Detection Assessment System called ICDS system, where it has been renamed as International Caries Classification Management ICCMS system, which is purely each tooth is taken into consideration. If you want to read more about it, this is the website. You can directly go to the website, their website, see those systems, how they're doing it. Lots of things are to be learned about it in our course. We detail about the tree, the ICDS tree to manage caries is being discussed there. So what is this system? The systems are divided into codes. The code 1 is like sound enamel. ICDS code 1 is like a sound enamel. No caries lesion, nothing. It's called sound enamel. Code 0, that's sound enamel. Now what is code 1? We can see a whitish lesion or a whitish when you dry the tooth. When you dry the tooth, imagine you clean the tooth, you dried the tooth. When you dry the tooth, you can see a visible change after air drying on the pits and fissures you can see. So that is code 1. So that is ICDS code 1. So this is the first sign of caries developing there. So this is, look at this, lesions are there on white like spot is there. Now look at here, ICDS code 2, if you see, without even drying, if you see a whitish spot on the labial surface or any surface of the primary dentition or the permanent dentition, occlusal surface, either whitish or brownish stain, if you see even without drying, it is called code 2. Code 1 was after drying. Code 2 is without even drying. You can see a whitish spot on any surface of the primary or the permanent teeth. So next one is localized enamel breakdown. So another stage, one more stage, it has gone to the next stage. The white spot has gone, now it is broken up. Localized enamel breakdown that has happened. Okay, with no visible dentine, no visible dentine is there. So that is called ICDS code 3. So enamel has broken down and you can see the underlying dentine there. Next one is underlying dark shadow of dentine with or without enamel breakdown. Like this, you can see an underlying shadow of dentine. You can see a shadow of dentine with or without enamel breakdown. You can see that is little more aggressive lesion. That's called code 4. So you are going into next level. It is spreading faster in the dentine. So I'll be talking more about the spread of dentine in the course, the importance of that and the hidden caries, everything comes in this code 4. You can't see any catch, or sometimes you can see huge halo, which is small catch, but when you open it up, you can see the entire dentine is involved there. So that is code 4 there. ICDS code 4, the small catch with this code there. What is ICDS code 5? Distinct cavity with visible dentine. It's a huge lesion. It's an open lesion, you can say. Enamel is involved, it is broken down. Dentine is also broken down. There is no hidden, it's a huge cavity that you can see. Patient says, little bit sensitivity. Sometimes eating food is going inside and sensitivity. Those kind of lesions you can say code 5, it comes under. Primary or anterior or posterior there. Code 5. And finally, code 6, extensive distinct lesion with visible dentine exposed, called ICDS code 6. Extensive lesion. Huge lesion with visible dentine, you can see. It may or may not involve pulp. So that is why ICDS has got a clinical classification. This is clinical classification. All you need to see is in this patient, is there is any clinical signs of like sensitivity, sweetness, pain to sweet, hot, cold, continuous pain, all those things come. That's the beauty of this. With this, you can definitely come to a diagnosis even without an IOPA. If this patient says I have a nighttime continuous pain, 100% pulp is involved. If the patient says occasional pain, that means if we can rely on the patient complaint and say that, okay, fine, I have done. So that is the beauty of this kind of classification, which can rely or more reliable onto that. Extensive cavity that is present there. You can see extensive with or without pulpal exposure that is present. Huge cavity with or without pulpal exposure. So if I ask you to identify the code of this, you can see this is code 4 because the distant cavity is present. It's open, dentine, and everything. So code 4, it is there. Look at this here, code 4, because there is a halo with or without exposure. The cavity is being filled, but there is a halo, so that's a danger. You need to remove that and try to do the filling and see what is happening, because there is a dentinal halo on the enamel can be seen. And here is code 6. You can see a huge cavity with clear exposed dentine that is present. Now, to learn more about that, there is something called radiographic classification to determine the dental caries. You need to know any interproximal caries are there. You need to take a interproximal. Your bite-wing radiograph is mandatory to identify that. So any interproximal caries, you need to take an IOPA, and then comes the radiographic classification like E1 and E2, which are the outermost enamel or innermost enamel, and D1, D2, D3. You would need to more about the radiographic classification of ICDS there. So interproximal caries, clinically, if you want to evaluate, what I use is a separator elastic and find out what is the caries lesion, how depth is the caries lesion is there. So in orthodontic elastomeric separators can be used to separate and find out and visibly to see. If in doubt, take a bite wing radiograph and see the radiographic radiolucency. whether it is in enamel, dentine, and plan treatment accordingly. So let me conclude by saying this session is just an introductory session to the caries, dental caries as a disease process. So treatment consideration will be covered partially on the next session, that is exactly 1 week from the next Sunday will be covered. So I will not be telling about drill, fill, and bill. I will not be covering clean, bill, and fill, but I will be covering seal, fill, and bill. That is the concept that is there. You can seal initial lesions before it developing, and you can bill it, and patient will be happy for that. That's going to be in the next session. So I'm going to cover preventive part, the application of web of possession, and lot more into sufficient component model, medical model of management, ecological model of management, and nexo model of management. That means the preventive aspect of dental caries will be more covered rather than surgical model. That you have to come to our class, I can tell you the surgical model, but more of preventive model will be covered there. So the need for cariology as a specialty in the clinic is very important, because this is the bread and butter of our practice. Be a pediatric dentist, general dentist, any dentist is listening to me. This is the bread and butter of our practice, because we have 78% untreated caries lesion happening there. Our overzealous statement, believing many companies, let me tell you, we believe many companies who comes and says that this is the best, it will stay, it is, the hardness value is 55, the normal biting hardness is 40, my composite hardness value is 55 MPa. Oh my God, it's better than gold. Let me put it. Please, we dentists follow into these companies, and we follow this, and we end up everything is gone, and finally the tooth go for root canal or extraction. Understand this as a disease and treat it. You can get a stent for 5 rupees. You know, the doctor in Bangalore invented a stent for 5 to 6 rupees, and that saves millions life. You don't need a 1.5 lakh surgery. That is what, understand dental caries as a disease. So a moment, please, dentist. We assume a lot, we fear a lot. If I tell all these things to my patient, will they listen to me? Oh my God, he will run away from me. No way, that everything on one day. I will never do that. Take the trust. There is a protocol for that. I told you the caries protocol for that. That evidence based, or that patient willingness based, that's a huge thing to talk about. We ignore a lot. Oh, that side, no, he's not bothered. He's bothered about this side. No, let me do this side. Let me fill this time and tell him that, let him come that time. Then only I will talk about it. We do not upgrade. Lots and lots of articles and lots of things are come. Follow up. Oh my God. How many of you tell, if you do a class 2 cavity, come after 3 months, let me have a checkup? How many of you tell? Ask yourself. Please do that. Let him come. If he comes, no, next side he may have a catch. He may have a doctor. This side is also, I am seeing, can you feel? He is, your feeling is staying there, and next side there is a catch, and he feels that discoloration. So he don't want that thing to happen on the other side. He'll be ready to do the filling there. Why don't you do that? Next 3 to 6 months, we never do that. So dentist also has a part to play in this. We have to change our attitude. Try to do this, what I say. Do not assume. Do not get fear to explain to your patient what to be done, what is happening inside the mouth. Show him. Use intraoral camera, microscope. Show him. He'll be happy to do that. Do not ignore other side or other teeth that is happening. Please do upgrade. Learn more. At least listen some webinars. Or now the pandemic situation such a way. Listen that glass, but talk down the point. At some point of time, you will be able to apply. And never ever any filling and scaling, if you are doing it, do not forget to schedule the patient for a follow-up for that. So what have we discussed? We have discussed about caries as a disease, understanding the caries as a medical versus surgical model, a new paradigm shift. Do not use your sharp explorer. keep it blunt. I'm telling you, for caries management, keep it blunt, bend it. I will be happy. Do not use that sharpest one for. You can use it for other thing, but not for caries detection. White spot lesion and its importance there. Informed decision making. That's the key role. This, if you know, you can change a lot of in your practice. And newer methods for caries detection, like I told you about the brushing and seeing it, diagnodont. That's a good tool if you can buy and do it. And ICDS classification that individually categorize each tooth, not the holistic. You have diagnosed that the patient is having dental caries, then forget it. Yes, you have a dental caries disease. You have malaria. So do you think you will only treat paracetamol? You only give paracetamol to suppress the fever? Don't you give chloroquine to suppress that or kill the pathogen there? That is exactly what I'm telling you. You have to kill the pathogen, control the pathogen, not drill and fill there. So that classification helps you to do that. And interproximal caries, this classification is good, but you have to identify, see it visually. These are a visual classification. So you might need a separator. Orthodontic separator elastic might be required. And to conclude you, it's a cariology. It's not just drill and fill, seal, fill and build that. So next session, I'm going to discuss all the matter which I've told you, lots and lots of preventive and newer methodology of things are going to come there. And Nexo model and introduction to that, because a class is going to come which highly 8-hour class on caries introduction. Just listen to it. Some point of time, you will be able to use that. And just to brush up so many programs. One of the program which I want to tell you is Cbct. And again, in the class, I'm going to tell you the decision change I've made with the Cbct in many of my cases there. So which cases, even caries, will you recommend Cbct is a question mark. And Dr. Utkal is going to come, and he's a very good friend of mine. He's going to explain about that. And sessional orthodontic, Dr. Benu said, it's filling up very fast. And our program of paid caries is again coming up. It's an amazing 8-hour program from 11 to 6. You will be with us discussing lots and lots of caries management and unconscious patient, which already Dr. Benu said. Just want to tell you, do not miss all these programs. If you have any inquiry, we are there in social groups. You can contact us in any of the social setup groups that if you want, we are available there either by email, Insta, Facebook, online, or website. And also YouTube, we are there. And these are our numbers. You can please do refer. Next Sunday is an amazing day. I would like to share with your friends. I know I've been repeated many times this. Next Sunday, so many new program, new things are added there. So if you want to attend and if you want to tell and talk to your friends, please do that. And thank you so much for your patience. I have taken 10 to 15 minutes extra because of this. I know it's a caries. Is you talk, you will never end in talking. Try to restrict from 11:20. Sorry, 8:20 I started. Now it is 30 minutes extra I have taken. Sorry for that, Dr. Binu.
Yeah, thank you very much. By the way, there is a small error in the phone number given there. It's 98470, not 8.
Sorry,
That's a
sorry for
small
that.
error. Sorry about that. So, Dr. Joby, this was a spark which you have given. So the questions are going to be little less, I feel. Let's see if there are any questions. Please type in the chat box in YouTube as well as Zoom. I am following both. If you have any questions, please put in the chat box. We will definitely answer right now. Now, yeah, there's a question in Zoom. So, which from Fatima? So, which advanced diagnostic caries detection tool among those mentioned do you personally use?
Dr. Fatima, I use only one diagnostic tool, that is elastomeric separators for interproximal caries. Then I use this one, between radiograph and visual examination. These three things gives me a clear picture of management of the caries. That's what, there is no require for a heavy gadget at this point of time when you start off and advancing the dental caries.
Can you mention about the chewable tablet again?
Yeah,
Dr.
there is
Venkatesh.
yeah, many companies are there in even which even Pepsodent has got these tablets, chewable tablets you can buy online. Those tablets, the patient has to chew for 30 to 60 seconds, and then they have to spit it out, and that's just the plaque determination. Okay, that gives you the patient awareness about how much plaque is available, or how the oral hygiene is there about. So that's a very cheap and very economical and very patient motivated things that you can use it. If your intraoral mirror also is there, you know what you need to do, just after chewing it down, and then you just dry it and just take a picture and show it to the screen. Immediately they will call for when can I have a next appointment for oral having or scaling or whatever a hygienist appointment they will ask for.
So, which is the ideal material used for deep dentinal caries?
Deep dentinal caries, the idea there is so many materials that have come. Even calcium hydroxide is available. You have biodentin, you have MTA. There is nothing called ideal material. All biomimetic materials can be used, provided your diagnosis of that deep dentinal caries is good. So, as I mentioned here, the more you leave your infected dentin, you have a greater problem. But if you leave affected dentin, fine. So your naked eye cannot distinguish is an infected or affected. So this kind of caries detecting solution, Carisol or caries detecting solutions will help you to identify between infected and affected dentin. So that will help you a idea. But always and always follow with your IOPA. The closer to the pulp, you need more biomimetic materials like a sub-base or a liner sub-base. You might require either dical, like a calcium hydroxide, AgIC. See, the success is your coronal seal should be good. All these material are calcium hydroxide based material, but the coronal seal, if it is good, you get a good success there, provided other factors of your diagnosis of the pulp is good.
Is indirect pulp therapy indicated, or should pulpectomy be done in cases of deep caries in young permanent teeth? Dr. Ume Salma.
Indirect pulp capping done again, that again depending upon the signs and symptoms, doctor. Again, I told you the signs and symptoms are important for us, and along with the radiographic diagnosis and clinical observation is important. If the signs and symptoms are not that severe, definitely indirect pulp capping would help, and radiograph says a sufficient amount of dentin is remaining, you can do that.
So according to you, what is the ideal treatment of arrested caries with attrition in primary molars?
Arrested caries lesion, primary molar. If patient doesn't have any signs and symptoms, or any difficulty in food impaction or anything is that, you can leave untreated. You can apply silver diamond fluoride if any signs and symptoms are there. But that attrition could be a sign and symptom of bruxism that is present. That has to be treated. You cannot leave bruxism untreated in any age group. That need to be listened. That's a different part. But if the patient doesn't have any problem of food impaction or sensitivity there, you can leave it untreated. And now the silver in smart application that has come, that can be done, so the sensitivity will be reduced. Whatever filling you do, if attrition due to bruxism is there, it is going to wear off, or going to, the fill is going to come off anytime.
Next question is from Dr. Supriya. Dr. Joby, I'm not very sure it's a question or it's a comment about one of your slides. I'm not very sure. I'm going to read it out. Thank you, sir, for your lecture. I was wondering why we used the ICDS score 4 for the dentin shadow around the restoration in one of the pictures you shared instead of ICDS score 7.
That is a modification that has come, doctor. That means there's already cavitation that has come, and then there is a shadow. I told you that there is a modification of that has come. That is why it has been there.
Dr. Deepa Venkatesh, do carisol take lots of time to dissolve the infected dentin, sir? Is it feasible in clinics with pediatric patients?
I told you it takes 2 to 3 minutes. So only those patients who allow you to do a rubber dam and a very cooperative patient, you can use that. If the patient is a little problematic, then you have to use a nitrous oxide or then any kind of sedation that you need because you need time. It's not like any other procedure where you apply immediately you get the result. You need to wait for 2 to 3 minutes at this point of time the material that has come. So you need the cooperation of the patient to do that. That is why now the newer methods have come. Irrespective of removing the infected or affected dentin, new material that your silver diamine that has come, it works wonders. Only thing you know how to apply, which cases that you apply, and which condition that you apply. That's all you need to know, and that even can cause remineralization of the affected dentin and infected dentin. Also can be little more hardened, and next appointment you can just remove that the top layer and you can do filling there.
What are your views on, Dr. Fatima again, what are your views on polymer burrs used to
Good,
remove
good,
only
good. I
infected?
use that. The next course that we are coming, we are showing them lively about the polymer burrs, the smart burrs, because they do not remove the infected dentin because they are very soft and very mild. So in the future, you can see a lot of polymer burrs instead of your carbide and your diamond burrs that's going to come. It's an amazing thing that have come up and that can be less harmful to your pulp because they are made of polymer, so they do not produce much heat as compared to that of your steel or carbide burrs or diamond burrs.
Sir, in which cases do you use carisol?
That depends upon the deep caries lesion, like now you have seen. So suppose ICDS 4, it's a very shallow cavity. I mean, halo is there. When you open up, you can see it's going in. So I don't want to take a risk whatsoever. I just remove all the soft thing and then I apply a carisol and then use a smart burr to remove that or an excavator to remove that. No, that depends upon any cases, depending upon. See, the point of using carisol is you have to do not want to go deeper and injure the pulp. So whichever condition you feel it's soft and deep, you try to use this. But cases where patient says that pain, high pain, night pain, open lesion, please don't use this kind of solutions there. It's going to increase that.
Dr. Ambuli has asked, sir, what is the success rate of indirect pulp capping in primary molars, especially MO cavities?
If you're asking Dr. Indirect pulp capping with the primary first molar, it is very bad. Okay, first molar, it is very bad because especially mesial pulp cones are very high. And if you're using it's very bad, do not use it for primary first molar. Second molar, it's still good provided your other signs and symptoms and your there comes the importance of using a blunt probe. You have to use, I always use a blunt probe after preparation of the MOD cavity and feel the dentin is soft, leathery, or still very soft, and you don't have any hardness in that. Then I don't go for indirect pulp capping. That means it's already involving. Better to go for a direct or a pulpotomy then. So then IOPA also you have to substantiate an IOPA there.
Can we use chlorhexidine or hypochlorite to disinfect the cavity before restoration?
Yes, you can use, but you have to use, if you're using hypochlorite, make sure you're using a rubber dam. Otherwise, it can injure the soft tissue there. You can use it so that there's so many studies which says that with this kind of disinfectant will disinfect the cavity and will give you a better, because even the dentinal tubules might have lodged your microorganism, which can be removed or which can have an effect or reduction with the use of this. So you can use it. There is nothing wrong in that, but I know you should be isolated and clean it before filling, doing your filling there.
We'll take one last question from the YouTube. Thank you, sir, for the informative lecture. How can we persuade and convince younger patients as well as their parents to understand and treat caries as a disease rather than an isolated event? That's a practice management question
Yes.
there. So I
Yeah.
think the first and foremost thing is that you have to understand that it is a disease and then make the parents understand that it is a disease. Am I right, Joby? Go ahead, please.
Exactly, exactly. The moment you understand this is a disease, then you start asking the question. That's what I told you. I showed you a form which we show in the class, which we give them the PDF form of that, and they have to do a case actually along with that. So that questions and thing that is why, Dr. Binu, when you give a consultation appointment, we take 20 to 30 minutes for that consultation appointment is just to take out the format sheet to make them understand this. No, and the parents, and many times the parents comes out and no, doctor told me this, Dr. Binu. So much thing, even after you explaining, Dr. Jovi told so many things when they come out. So
See,
that
when
is
I see a patient in my clinic first, and if it's a young kid and I see cavities, I say that you have to come on this date, this time to meet Dr. Joby. So they come that day. They think that that day they are going to get it filled. But they go inside that room, 30 minutes, 20, 30 minutes, they have a chat with Dr. Joby. Dr. Joby tries to make them understand that, it's just not sit there and fill it. He can just fill it right there and get some money right there. But that was one condition he had the day he joined my clinic, as I would say, that it's just not money making there, making them understand what is going on. So that is the preventive part of it. It takes time. And out of 10, maybe 3 or 4 might just go off. They might just go off. I mean, come on, he was talking about big things, not to eat biscuit, not to eat ice cream, big thing. Come on, that's not practical. I'll go to some other clinic and do the filling. But if the other 6 out of 10 understands this, that 6 out of 10 is your patient, they're going to be with you. The younger siblings, even the father and mother is going to be with you. Am I right, Joby, on that?
exactly, exactly. So many times they ask, sir, is it possible for us to apply fluoride for adults? And and the sealants, is it possible something can be done for me itself? So many times they ask that, and those are your patients there.
Exactly. All right, we are done with questions. Thank you so much once again, guys. Those who are listening to me now, do not miss the next week, same time, 8 p.m. Do not miss it. And then those who are interested in taking this further, next step forward, please do not miss that chance to attend one full day program on caries management, each and every material, how to use it, and the disease progress, the rating, all that case sheet form, practice management part, all put together in one full day. If you're serious about it, please attend that program. This may not happen again soon because we had a batch last month with more than 92 people, and from real pressure we decided to have one more batch, and that batch is also getting full now with very few seats remaining. So we are restricting it again. So those who are interested, do not miss out that one full day program. And that costs what? 3,450. Am I right, Dr. Jabi, on that? 3,450. 3,450 rupees one full day. I would say 3,450 rupees is nothing. But that one full Sunday which you're going to miss, yeah, the time might be more valuable, but 2 patients, one patient you treat well, that money and time is worth it. Thank you so much once again, all of you, for the time and dedication and for the interest shown to all our programs. And can we call today, Dr. Joby?
Yes,
Thank you very much. Good night, one and all. See you next week, same time, 8 p.m. Do not miss it. Thank you.